Today, we will walk step by step through a clinical case presentation of amyotrophic lateral sclerosis, or ALS, using this structured case sheet. ALS is a progressive neurodegenerative disorder that primarily affects the motor neurons, the nerve cells responsible for controlling voluntary muscle movement. Over time, degeneration of these neurons leads to muscle weakness, wasting, and ultimately loss of voluntary movement. Let us begin with Section 1, Patient Details. In this clinical scenario, the patient is a 58-year-old male whose identifying information has been anonymized for confidentiality. He was admitted recently for evaluation of progressive neurological symptoms. His occupation is listed as an architect, which is useful because it implies that his work likely requires fine motor coordination, drawing precision, and detailed hand movements. These occupational demands become relevant when we analyze the patient's presenting complaints, especially symptoms involving the hands and fine motor tasks. Moving to Section 2, Presenting Complaints. The patient reports progressive weakness in the hands, particularly difficulty holding objects. For example, he may notice that he drops keys frequently or struggles with small tasks like buttoning a shirt or writing. These early symptoms often represent distal muscle weakness, which is common in ALS. He also experiences difficulty performing fine motor tasks, which further suggests involvement of the small muscles of the hands. This is particularly important because degeneration of lower motor neurons supplying the distal muscles can lead to early loss of dexterity. Another symptom reported is frequent tripping and stumbling while walking. This indicates weakness in the lower limbs or impaired coordination due to motor neuron dysfunction. The patient also complains of muscle cramping and twitching, medically referred to as fasciculations. Fasciculations are small, spontaneous contractions of muscle fibers that are visible under the skin and are a classic feature of ALS. These occur because of irritation or degeneration of the lower motor neurons. Finally, the patient reports slurred speech, also known as dysarthria. This indicates possible involvement of the bulbar muscles, which are controlled by motor neurons in the brainstem. Bulbar involvement affects speech, swallowing, and sometimes breathing. Together, these symptoms, progressive weakness, fasciculations, gait disturbance, and speech difficulty, raise strong suspicion for a motor neuron disease. Now we move to Section 3, Past Medical History. The patient has a history of well-controlled hypertension and hyperlipidemia. These conditions are common in middle-aged individuals and may not be directly related to ALS, but are important to note because they can contribute to other neurological conditions like stroke. The family history is described as non-contributory for neurological disease. However, the case sheet also mentions a previous unspecified sibling death, which might warrant further investigation. Although most cases of ALS are sporadic, about 5 to 10% are familial, meaning they occur due to inherited genetic mutations. Because of this possibility, clinicians often ask about family history of neurodegenerative diseases, muscle weakness, or unexplained neurological deaths. Now we proceed to Section 4, Pathophysiology or Mechanism of Disease. ALS is fundamentally characterized by degeneration of motor neurons. These include both upper motor neurons, located in the motor cortex of the brain, and lower motor neurons, located in the brainstem and spinal cord. The disease process involves several complex mechanisms. One major mechanism is protein misfolding and aggregation. Certain proteins inside neurons fail to fold properly and accumulate abnormally. These abnormal protein aggregates disrupt cellular function and contribute to neuron death. Another mechanism is excitotoxicity, which refers to excessive stimulation of neurons by neurotransmitters such as glutamate. High glutamate levels can lead to increased calcium entry into neurons, ultimately causing cellular damage and death. Mitochondrial dysfunction is another important factor. Mitochondria are responsible for producing energy in cells. When mitochondrial function becomes impaired, neurons cannot maintain their energy demands, leading to degeneration. Additionally, oxidative stress plays a role. This occurs when harmful reactive oxygen species accumulate and damage cellular structures including DNA, proteins, and membranes. Finally, neuroinflammation contributes to disease progression. Activated immune cells in the nervous system release inflammatory mediators that further damage neurons. Together, these mechanisms cause progressive degeneration of both upper motor neurons and lower motor neurons. Upper motor neuron loss results in features such as spasticity, increased muscle tone, and exaggerated reflexes. Lower motor neuron loss produces muscle weakness, atrophy, and fasciculations. Over time, the disease progresses along a timeline. In the early phase, symptoms may be mild or nonspecific. Between 6 and 18 months, patients typically develop focal weakness, often beginning in the limbs or bulbar muscles. As the disease advances over 2 years or more, progressive paralysis may develop, affecting limb movement, speech, swallowing, and eventually respiration. Now let us examine Section 5, General Examination Findings. During clinical examination, the patient demonstrates distal limb weakness, particularly in the hands and legs. The weakness is often asymmetric, meaning it affects one side more than the other initially. Muscle tone examination reveals spasticity in the legs, which indicates involvement of upper motor neurons. At the same time, the hands show muscle atrophy, suggesting lower motor neuron involvement. This coexistence of both upper and lower motor neuron signs in the same patient is a hallmark feature of ALS. The patient's posture and gait may also appear abnormal. He may have a clumsy gait, difficulty lifting the feet, or imbalance while walking. Vital signs, including temperature, are stable, which indicates that the symptoms are unlikely due to an acute infection or systemic illness. Now we move to Section 6, Systemic Examination Findings. A detailed neurological examination reveals a combination of upper motor neuron and lower motor neuron signs. Lower motor neuron findings include fasciculations, which are visible muscle twitches caused by spontaneous activation of muscle fibers. There is also marked muscle atrophy, particularly in the hand muscles. The image highlights thenar muscle atrophy, which involves wasting of the muscles at the base of the thumb. This leads to reduced grip strength and difficulty performing precision tasks. Another lower motor neuron feature is tongue atrophy. The tongue may appear thin and shrunken with visible fasciculations. This contributes to speech difficulty and swallowing problems. Upper motor neuron signs are also present. These include spasticity, meaning increased resistance to passive movement due to increased muscle tone. Reflex testing shows hyperreflexia or exaggerated deep tendon reflexes. Additionally, the Babinski sign may be positive. When the sole of the foot is stimulated, the big toe moves upward instead of downward, which is a classic indicator of upper motor neuron dysfunction. The coexistence of these upper and lower motor neuron findings strongly supports the diagnosis of ALS. Next, we move to Section 7, Investigations. The most important diagnostic test is electromyography, or EMG, often performed together with nerve conduction studies. EMG detects electrical activity in muscles. In ALS, EMG typically shows evidence of active denervation and reinnervation. This means that muscle fibers are losing their nerve supply, while surviving neurons attempt to compensate by reinnervating the muscle. Nerve conduction studies help rule out other conditions, such as peripheral neuropathy. Another important investigation is MRI of the brain and spinal cord. MRI is usually normal in ALS, but is performed to exclude other conditions that might mimic ALS, such as spinal cord compression, tumors, or multiple sclerosis. Blood tests may also be performed. These include thyroid function tests, erythrocyte sedimentation rate, creatine kinase levels, and autoimmune screening. These tests help rule out metabolic, inflammatory, or autoimmune disorders that could produce similar symptoms. Because ALS can eventually affect breathing muscles, doctors also perform pulmonary function tests, or PFTs. These tests measure respiratory capacity and help monitor disease progression. Finally, we come to Section 8, Management. Currently, there is no cure for ALS, but several treatments can slow disease progression and improve quality of life. Disease-modifying therapy includes medications such as riluzole, which reduces glutamate-mediated excitotoxicity. This medication has been shown to modestly prolong survival. Another medication is edaravone, which works by reducing oxidative stress and may slow functional decline in certain patients. In addition to disease-modifying therapy, symptomatic management is very important. Patients may require medications to manage muscle spasticity, excessive drooling, muscle cramps, or depression. Supportive care also plays a major role. For example, non-invasive ventilation, or NIV, may be used when respiratory muscles become weak. This helps improve breathing during sleep and prolongs survival. Some patients may eventually require PEG tube placement, which stands for percutaneous endoscopic gastrostomy. This feeding tube allows adequate nutrition when swallowing becomes difficult. Rehabilitation therapies are also essential. Physical therapy helps maintain mobility and reduce stiffness. Occupational therapy assists patients with adaptive tools for daily activities. Speech therapy supports communication and swallowing function. Management of ALS typically requires a multidisciplinary team approach, involving neurologists, respiratory specialists, rehabilitation therapists, nutritionists, and palliative care professionals. As the disease progresses, discussions about advanced care planning and palliative care become important. The goal is to maintain dignity, comfort, and quality of life for the patient. In summary, this case sheet illustrates the classical clinical features of amyotrophic lateral sclerosis. The key diagnostic hallmark is the combined presence of upper and lower motor neuron signs, progressive muscle weakness, and supportive findings on electromyography. Although ALS remains a devastating neurodegenerative disease, advances in supportive care, multidisciplinary management, and emerging therapies continue to improve patient outcomes and quality of life. Understanding these clinical features allows clinicians to recognize ALS early, differentiate it from other neurological conditions, and initiate appropriate management.